So a little bit about what co-clinical means. We are part of, Duke is part of a consortium which is called co-clinical imaging research programs. And the idea here is there is a clinical trial, and in parallel, there should be a preclinical trial. So there is an implementation of the clinical trial at the preclinical level. And in particular, this SEER program is about trying to make the imaging equivalent. You have the imaging at the clinical trial with clinical systems. You'd like to have something similar at the preclinical level. So I'd like to start as a motivation with this idea of bedside to benchside to bedside, actually. And if we talk about, for example, the drug, but in this context, let's talk better about nanoparticles that can be used for imaging. Some of these nanoparticles, as I show you, can be used for theranostics. In this particular case, we have a liposome that has inside some iodine. And so we'd like to study perhaps different contrast materials. We will have a preclinical system, a photon counting preclinical system. This is a Mars scanner. Is not what I'm going to show you or use it because we don't have that. We have our own system that we have built. And on the right side there, on the clinical side, you have the, let's say, the Siemens photon counting system. So the objective of this talk is actually to look at, first of all, we want to start with spectral separation for some of the high Z elements. And we want to look in this co-clinical paradigm. So we want to go maybe back and forth between the preclinical and clinical level with our imaging photon counting centered, let's say. Okay, so let's start with the elements that we are going to look at. So we have calcium, of course, but then all the others, they are elements that they have a KH, high Z. So if you look at their KHs, we have from iodine 34, then we have gadolinium at 50 keV, and then we have tantalum here, hafnium, that they are close to 65. And then we have bismuth around 90. So the phantoms that we're going to use, they are in the lower part of the slide there. Let's see if I can. So we have, first of all these elements with different concentration going from 10 to 0.625 milligrams per ml. And we have the clinical phantom and the preclinical phantom. We have the spectra, of course. We're going to image at 120 kVp with both systems. And on the clinical side, at least the configuration that we have now at Duke with this dual source photon counting system from Siemens, we have only two thresholds that they are available. So it's 20 and 65 kV. But at the preclinical side, we're going to add another two thresholds, one at 34 and one at 50. And it's clear why, because you have the iodine KH and the gadolinium KH. So that was our choice. Okay, so I'm going to show you also some animal experiments. These are some mice that have a soft tissue sarcoma. And we're going to use, as I said, as an example, these liposomes. They can encapsulate either iodine or gadolinium. We're going to inject, again, a little bit about the liposomes. They're about 100 nanometers in size, and they have that load, the contrast agents, which is essentially the clinical contrast agents, iohexol inside. They are pegylated. They live in the blood for a long time. They are cleared then by the liver and spleen. So we have two types, one of iodine and one of gadolinium, and then we inject them in these tumors. First, we inject the gadolinium, and then 3 days later, we inject the iodine liposomes. And to understand why, and then we kill the mice because we want to take them to the hospital, and it's hard to take, live mice to the hospital. So we image them ex vivo on the clinical scanner. But if you look at to understand better why we do that separation by 2 days or 3 days, and what happens with the tumor, you have the tumor there in the ellipsoid, and you see here nicely the vasculature, because we image the liposomes, they are blood pool, the iodinated ones. But what you see green there are the other liposomes with gadolinium there. The reason they accumulate in the tumor is this effect, which is called enhanced permeability and retention. Is used also for drug delivery. Exactly these liposomes, they are actually used for drug delivery. They are called doxil. They can have doxorubicin inside, and they're used for chemotherapy. So we have, in a way, a surrogate for the doxil, just having the iodine or the gadolinium inside, with which we can essentially study that drug delivery. So they accumulate in the tumor, they circulate and they accumulate because you have that leaky vasculature in the tumor. Okay, so I believe previous speakers, they introduced the dual source Natom scanner from Siemens. I just want to draw attention to the very high resolution that it's advertised it can deliver, 110 micrometers essentially in plane. Well, I'm going to show you 150. We were not able to get 110 so far, but I guess it's possible. Here's our phantom. Took it to the clinical scanner, 2 thresholds. The protocol that we were able to use here was not with 150, but was about 300 microns in plane and about 400 microns slice thickness. And you can see here the VMI at 70 keV. You do different columns there. They show different concentration of different materials. And then we have the iodine map also that the scanner provides. And you can see that in red, it appears that the iodine on the bottom. But you have the other materials that they appear in the iodine map, which are classified as iodine. Okay, so our preclinical scanner, it's a hybrid scanner. So first of all, it has clinical X-ray tubes, which makes things, let's say, closer to the clinical side. But it has a photon counting detector from Dectris that has 4 energy thresholds, and the selection is given there. And then we also have an energy integrating detector, which we don't use in this particular study, but sometimes we do this hybrid reconstruction and hybrid scans like that. We aim here for a reconstruction of about 125 microns. And as I said, the KVP is the same as the clinical one. And we image that phantom. Now, we reconstruct jointly. I'm not going to go into details of image reconstruction. Darin Clark is there, and you can ask him more about this. But in essence, this is an iterative reconstruction that it's using this multi-channel, multi-energy data. Sometimes we apply it for time as well. And then we perform some image-based decomposition by matrix inversion using a sensitivity matrix. An example is shown here. So we have, let's say, iodine, Darin P, and CS, and then we have the sensitivity matrix and the measurements. And then we do a lot of combinations here. We try to decompose based on the dual energy side, the energy data on CT, on the preclinical and clinical side, or using the 4 thresholds on the preclinical side just to see what is possible. Noise of figures of merit. We look at noise. We looked at dual energy index, because I think it's good to see how different elements they compare, and also use the condition number of the sensitivity matrix. And we know that the lower condition number, the better the decomposition. Okay, so let's look at the comparison between micro CT, let's say preclinical side and clinical side. These are the dual energy indices, and you can see that they are not exactly the same. But what I want to point out is, first of all, there are some elements like tantalum and hafnium that they have negative dual energy index, which is very interesting, which means that the high energy linear attenuation is higher than the lower, while for the other elements, it's the opposite, right? So this tells us there is something there, because if you would have to choose another element, let's say in a multiple probe kind of experiment, it's better to choose one of those because they are more dissimilar, for example, from the iodine and gadolinium. So the reason they are also like that is because we have 2 thresholds. We have a 20 and 65, and they have a KH around 65. So if you image with a threshold that's very close to their KH, then you have a higher attenuation in the 65 than in the 20 for the tantalum and the hafnium. Okay, so now go through different decompositions that we made with the clinical data, again, image-based, and we look at iodine and calcium. And the goal here is to show that, you know, although these images from the scanners, they are not that noisy. I mean, the levels are 8 and 10 Hansard units. But if you perform some denoising, we have this rank sparse kernel regression denoising that we perform, you can see that the decomposition, in this case, iodine and calcium, improves. So those material maps become better. If you go with micro CT, like in this case, then you have huge amounts of noise. So by comparison, the 65 energy that we have there, we have a level of noise of about 246 Hz. And then it becomes, really important that you reduce that noise. We get it to something like 20 Hz after the denoising that we have. And you can see that, again, the decomposition, everything apart from iodine is mapped in a calcium map. And that's how it looks. Now, we tried the other combination, iodine, gadolinium, iodine, tantalum. On observation here, if you look at the tantalum and the iodine, there is a yellow arrow there. You can see in the iodine tantalum that you kind of decompose better the iodine, lower concentration than in the case when you decompose with gadolinium, which would argue for the fact that if you would have to choose another element, tantalum or hafnium would be much better than gadolinium in this kind of combined studies. And the same thing on the preclinical side. Now look at the condition numbers. You can also see that the condition numbers for iodine and tantalum, they are lower, which means better decomposition, and they are similar, let's say, at the clinical and preclinical level. Now we go and look only at the preclinical data because we have 4 thresholds, and we want to see what is possible in terms of decomposition. So we use all 4 thresholds here, and we look at the 3 materials decomposition: water, iodine, and calcium. What I want you to see is that you can see in the iodine close to 0.625 milligrams per ml, which is pretty good. I wouldn't argue that, we satisfy the Rose criterion there, but it's still kind of visible. And then we go and we add another material. So in this case, we have two KH materials, iodine and gadolinium, iodine, water and calcium. And you clearly see the 2 materials plus calcium separated from water there. If we add tantalum, of course, that works too. And we also can have 4 materials, 4 measurements, 4 materials. In this case, the body of the phantom, which is PLA, it appears to be put into one of these material maps. So it goes into tantalum in this case. That's why it looks bluish like that. But nice separation. Hafnium and tantalum, they are grouped together because they are 65 and 67 in terms of the KH. So it's not possible, and we are not accounting them in different material maps. As well, calcium and bismuth here, they are put together just because we didn't have more measurements to separate them. It's interesting to look at this plots of, if you like, the sensitivity over the different energy bins, and you can see a flat for gadolinium for the 3 measurements, and then it drops at 65. But and of course iodine, it drops all the way for all the measurements, and but you see at hafnium and tantalum there, it goes up at 65 as I was pointing. The dual energy index becomes negative. And if you look at normalization to the iodine one, you can see that apart from the 20 and maybe 35, everything else, bismuth, tantalum, hafnium, and so on, and gadolinium, they are better than iodine. So they would be preferred at higher, I guess that was known. So why tantalum and why hafnium? I believe I made the case that from the point of view of imaging, they are behaving well. And people are already making this or trying this contrast agent. So these are some examples with tantalum oxide-based contrast CT in a pig. On the left side, you have iodine, tantalum oxide on the right side. You can see much better the iodine. The same thing for hafnium-based on the right side of this screen. And you can see no contrast in the middle and much better kidneys there for hafnium than for the iodine. Just to mention, tantalum oxide is in clinical trial as well for augmenting radiation therapy. So it has this potential for being used as a theranostic agent. I believe CT will help very, very much with this kind of cancer treatment. So let's go to our mice. These are some of the data that we have acquired in mice with sarcomas here, the 4 energies that we have preclinically. And then we have the clinical scan of one of these mice. Remember, this is 300 microns in plane and 400 microns. And then the decomposition that we've done here is gadolinium iodine. So you see in gray a gadolinium map, and in red an iodine map. You see in the liver the gadolinium, because that's the contrast agent accumulated is taken by the liver and spleen. So there was some separation there. But if we image with the preclinical side, focus on the tumor here and compare. So we did a 2 material decomposition. You can see nicely the gadolinium, the iodine, the gadolinium not so much. There is not much accumulation in this particular tumor. But if you go to 4 thresholds and 4 materials where we have P and CS, iodine and gadolinium, then, you know, with fancy rendering, you notice that with 4 materials, we start seeing the vessel in the tumor there much better than with 2 measurements, with 2 materials. So again, what this shows is that if we increase the number of measurements, we will be able to separate better, and also if we increase the spatial resolution. In the micro CT case here, the voxel size is 125 microns. There is about 300 microns in plane, 400 microns out of plane. So the point is that the scanner is already able to provide this 150 microns almost, which is the clinical scanner, which is amazing. So the details of this, you know, imaging mice with a clinical scanner, this is almost make you think, wow, do we really need micro CT from now on? But the level of noise, of course, is huge. So that shows we need better denoising, no doubt. And we were able to do denoising going from 150 to 20 something Hounsfield units. And the good thing is that you have a huge field of view. You can image many mice in the same time on the clinical scanner. So in conclusion, we looked at these elements and we kind of found that tantalum and hafnium, they were very well aligned, let's say, with the thresholds, at least they are fixed for us at Duke now with the 65, the keV that we have on that scanner. And although, you know, what I think is the other message is that there is potential there to have on the clinical side higher resolution, both on the spatial and spectral side. And I believe that the experiments that we did preclinically shows a proof that we can gain something by trying to use those, you know, higher resolution, both on the spatial and the spectral side on the clinical scanner. And also, I think that this kind of co-clinical photon counting CT can bridge a translational gap for both algorithms and also the development of these new contrast agents, especially, for example, this new promising field of theranostics. Thank you.
Yeah, nice work. So it seemed that the tantalum and hafnium, their K edges seem to coincidentally line up with your threshold. So if you could set your threshold to something else, I mean, would there be other contrast agents that you would find better or more suitable?
Well, it depends on how many contrast agents are you going to use. I mean, for 2 contrast agents, that 65, it was perfect for tantalum and hafnium. So if we would have more, so in our case, preclinically, we had 20, 34, 50. So 50 was just before that 65, let's say, sorry, that they were great for separation of those elements in particular, and also for the others. I mean, we were able to separate 3+ water, for example, or I don't know, optimum thresholds. I think that's a whole study in itself, you know, what would be the optimum thresholds for certain combinations, or this was more like an educated guess selection of those thresholds that we had.
Thanks.
Okay, we have time for maybe one more question. All right, if there are no more, let's thank the speaker again.